Hi there and welcome back to the Old School RN. Thank you so much to everybody who has subscribed and commented on my channel. I'm exceedingly grateful. It's been amazing to see the number of people who've sent me very great messages, privately and on the actual forum itself. It's wow, I don't know what to say. But it's very interesting that the people who've replied and commented have all said exactly the same things as me. Not surprising, of course. It's an ongoing problem within the NHS and one that definitely needs sorting, that's for sure. As well as the NHS, I've been following obviously on Lucy's trial, and I am going to be attending in a couple of weeks. All I'll say is it's a open forum. There'll be media, there'll be experts, etc. at this event that will look at the intricacies of Lucy's trial and how wrongly some elements, the things like statements that have been kept out of the trial, other people's knowledge and opinion and support for her, and the state of the unit, all kinds of documents that have not made it into the papers, and hence why, the Thirlwell inquiry was halted, etc. And rightly so, because this whole incident needs an overhaul. And I think on that note as well, again, from avid reading and research, that's why it's been taking me so long to come back. All I've done is research, read. And the way that a medical or a hospital trial is handled is very, very different to how a normal trial would be held. I would say that in terms of any specialist area. Criminal law is criminal law. However, when you're looking at potential or alleged criminality within the NHS, all of that information is very complicated, very in-depth, and it's another language. Medical language is another language to the public to try and decipher. And for the jury to try and decipher that, it must have been horrendous for them, because every other sentence would be stopped, I'd imagine, to explain and say what the terminology is. My key message on here isn't just to highlight the failings of the NHS, which are, in my opinion, deliberate, but to also give the on-the-ground kind of perspective of what actually goes on day to day as a nurse front line. Now, in Lucy's case, and I've made a couple of points on this, the reports are all saying that they cast doubts on the safety of the conviction and the terms that she was convicted on her case. Okay, we all know that. There are lots of channels that give gross detail about what happened to those poor babies, and gosh, I feel for those parents. It must be horrendous for them, what happened to each baby in each case, and that there was a very senior review of high-end perinatal doctors, doctors who really specialise in intensive care and the high dependency care and special care of babies. And for anybody who doesn't know, special care means keeping an eye on a baby. They might need a little bit of supplementary oxygen, but by and large their lungs are working, they just need a little bit of help. Some feeding or added feeding, because a baby breastfeeding or feeding from a bottle will use up a lot of calories, and those calories on top of a minor respiratory issue that needs oxygen is too much energy. It's like saying if you've got the flu as an adult, go and run 100 meters up the road. It's hard. So rather than a baby sucking from a bottle, they're sometimes given supplementary nutrition. So they'll have what's called a nasogastric tube inserted, and it's a tube goes up the nose, through the back of the throat, down into the esophagus, down into the stomach. And feeds can be given, but little and often, because babies have a suck reflex and need to satisfy that reflex. And then the rest of their nutrition can be given via the nasogastric feed. So that's what special care unit is. It's for sort of an overview. They're a little bit sick, they might need a bit of observation under a lamp if they've got a bit of jaundice, but that's it. Then you've got the next level of babies who require some kind of support. So you'll have heard or read about CPAP, continuous positive airway pressure. It's used on adults as well. And it was one of the big things when COVID was out, i.e. Dyson were commissioned to make lots of these CPAP machines. They are not the same as a life support, completely different. CPAP machines to use during COVID. And of course, babies, children and adults have these in intensive care or in hospital care. So CPAP is basically a way of maintaining a pressure within the airways so that you don't have to breathe as hard. So if you've got lung inflammation, like pneumonia, okay, of whatever cause, when we breathe in and we have that cycle, and there's pauses in those cycles, you know, of fractions of a second in some instances, but I'll keep it plain. It's hard at times to get my nurse head on. CPAP keeps the pressure within the airways, so you don't have to breathe as deeply, so you can just breathe gentler. It's less traumatic to the diaphragm, to the lungs. It enables extra oxygen to be given, and it's a way of supporting the lungs until they get better. If they get worse, then you move on to the next stage, which is proper critical care. So that's the same for whether it's neonates, whether it's young children, older children or adults. Life support. So what do we mean by that? Life support is a ventilator. It's plugged into the wall. It has air and oxygen, which is mixed in the machine. They're often microprocessors these days. I trained on the old microprocessors and on the processors, but the physiology is the same and the pathophysiology. That means when the physiology goes wrong, it's the same. So you program in according to the size of the child, size of the adult, size of the baby, different programs, for want of a better word, and frequencies of breath. And you can alter the oxygen status, so you can have 100% oxygen, you can have 90%, where 10% is a bit of room air mixed in, and various levels in between. So somebody who requires ventilation is often so poorly that their lungs cannot allow, at a very micro level, cellular level we're talking about here, the molecules of oxygen to cross those tiny little alveoli, those tiny little balloon-like sacs. Not all of the oxygen can pass out into the bloodstream to be circulated and used by the body, and the waste products, i.e. carbon dioxide, to be removed. Okay, so the lungs aren't working, they require full on. To have children, or babies or adults in that situation requires very high level nursing care, very high level. You're talking highly trained, specialist training, and not just the theory training, the hands-on as well. And then to leave a nurse with such a patient that they can cope alone, deal with problems as they arise, know when to call for medical help, know when they can handle situations themselves, like if a patient coughs, an alarm will go off on the ventilator because the settings will be altered because the patient's coughed. It could be secretions in their oropharynx, i.e. the back of the throat. It could be, you know, that they're just coughing up sputum. So it's my warning as a nurse in intensive care to suction those secretions away, either down the endotracheal tube, which goes into the throat, into the trachea, and down into the lungs, because the trachea sits at the front here and the esophagus sits at the back, so they're not to be confused. A nasogastric tube goes into the esophagus and the stomach. Yeah, there are structures in between, and then you've got this rigid bit with the rings of cartilage, like a little ladder, which is the trachea, which goes off into the bronchi, which then goes off into the lungs. And that tube usually sits before the bronchi become two. Okay, so the ventilator pushes breath into that tube, into the lungs, takes what's expired out and out through the ventilator. Okay, and then there are all the settings that, and alarm settings as well, that can go off when you're doing a procedure. And it's not uncommon for a nurse who's, say, performing suction, to silence the alarm. You can't switch these alarms off. It's impossible. There's a setting on them that has a timer. So for a young child and a baby, you wouldn't have a 3-minute alarm reset. That's too long. That's for an adult. So according to the child's age and size and weight, that alarm can only be silenced for a short time. You can't switch it off. That's how it's made. And the same with the alarms that are on the heart traces and other pressure traces, etc., etc. You can't switch them off. You can silence them for a short period of time and then they come back on. So if you're doing something, you're disrupting all those settings you've put in to your ventilator and to your display unit. So once you switch them off, say for an adult, 3 minutes, you're doing your suctioning, you're turning your patient, you're doing whatever, fixing all your wires and lines again, and then adjusting them, resetting them, and the alarm goes back on when the patient's settled. If they move and jiggle, the alarms will go off because it's a machine and it will count any movement as a high heart rate or a change in pressure. When it isn't, it's called an artifact. So in summary, what I'm trying to say is that knowledge, that experience comes with time and comes with working with lots and lots of different patients with lots and lots of different conditions. So as a nurse, you have to know the difference between a patient having a little cough and the alarm goes off and resets, to a patient who's having what's called a pneumothorax, spontaneous pneumothorax, where air gets in the chest for whatever reason and the chest collapses. Now that's a major emergency, because what you do not want is a ventilator pushing in a mixture of air and oxygen or oxygen into a patient when that chest is already being squashed because of the dynamics of the chest, which I won't go into here because it's too long. I can do, if anybody requests it, I can do videos about that. Cardiothoracics and emergency things are me. That's what I've done for 40 years. Anyway, I'm digressing. So when I'm reading about Lucy's, whether the alarms were switched on or off or not, and whether the doctors heard it, it's a bit strange, because that remark in and of itself could be, he heard an alarm go on and then the alarm went off. That can happen if an alarm has reset itself. But regardless of an alarm going off, it's what the nurses are doing. It's what the nurses are dealing with. If I have a patient who is going off on me, i.e. deteriorating for any reason, I intervene. I start something to save their life. So I might take them off the ventilator. I'll put them on what's known as a water circuit, which is a bag that inflates with 100% oxygen, and I can bag or squeeze a bag that allows air into the lungs. And that happens with children, only it's a bit different with children because the bag itself is open-ended, and there are reasons for that because of pressure. So if a nurse is taking on board, I need to get this patient off the ventilator, I'll put them on my manual water circuit, I'm going to hand ventilate the patient, I can feel through the bag what those patients' lungs are like. Are they stiff? Have they changed? Are they compliant and the chest is expanding? I'm looking at the saturation probe. Are they saturated with oxygen to the right level? What is going on with them? Now, with neonates and babies, they have a difference in their physiology in that they have what's called fetal hemoglobin. Now, fetal hemoglobin differs from adult hemoglobin in many ways and for many, many reasons. Again, too long for me to even go into here. So dealing with neonates is again like a specialty within a specialty. So if I, as an adult and children's intensive care nurse, went into neonates, there are some commonalities, but there's also a lot of things that are very different, and I would have to train on those differences. Yeah, so drug dosages, drug measurements, how you calculate babies' weights, that's key to drug dosage. Their kidney function, their liver function, their general biochemistry, their fetal hemoglobin and oxygenation, the pressures of oxygen. You know, oxygen given to an adult is different from a neonate because a young baby can end up with blindness, they can end up with brain damage, they can end up with all kinds of things because of the way the molecules of oxygen change within the body in certain patients. And the same with drugs. Drugs can change within the body of patients in intensive care. That's why it's so highly specialised. So coming back to my point in a very long way, if the Countess of Chester Hospital had a special care baby unit for low-level, more than usual observation of babies, why did they have ventilated babies in there when the infrastructure wasn't in place? That's me as a nurse reading between the lines. That I don't understand. Another thing that I noticed about Lucy's case is that North Wales, the hospitals that sent babies to Chester, were taken, these higher level babies who needed more care, because there were issues with the special units in Wales. Now, there's always been issues with hospitals that are on borders with Wales. Trust me, I know this. And it's about funding. It's about money. Because the Welsh health boards versus the British, the England boards, compared to Scotland and Northern Ireland, Southern Ireland is private, etc. But particularly Wales and England have different tariffs, yeah, different amounts of money. And hospitals that are on the border or near the border want to attract money to be spent on whatever. That's up to the public to look into that one. Very interesting it is, though. So, for example, Telford and Shrewsbury. Telford is being closed down because it's further away from Shrewsbury Hospital. Shrewsbury Hospital is near to Wrexham Mailer, and of course, that's in the Welsh border. So, taking patients from Wales with Welsh addresses and Welsh ambulance personnel, WMAS coming over, sorry, WMAS, Welsh ambulance service coming over to England, means that that trust can apply for more money. So there is a component here, I feel, that finances may have played an issue. Egos as well. There are some, not many I have to say, but humanity is full of extremes, as we know. There are some people who want their unit to shine. Now that's great. You've worked hard in your career as a doctor and a nurse. It's been uni, studying in your spare time when everyone else is out partying. Yeah, we had parties. Yeah, we did have a life. We were young. But we've also spent time clipping our social time, not taking annual leave for leave, and sitting and writing and studying for exams all evening and all night in many cases. You know, we work hard to get where we are. I, for example, didn't get all my qualifications given to me. I had to work for them. I had to study. I had to work in different hospitals and be assessed and, you know, have a consultant doing my oral exams. There's nothing more scary than a consultant putting you on the spot and saying, right, here's an x-ray, nurse, tell me about this patient. And you have to know. In intensive care, you have to know, even down to the basics. Was the x-ray the right way round? Because they'd often do things like that to catch you out. So you knew that the anatomy was correct. So when you were looking at different aspects of the lungs, you knew you were looking at the right part, you know. And if you didn't pick up on that. The doctors would say, well, is it the right way round? Is it AP or PA, anterior posterior or posterior anterior? Which, if anyone works in intensive care, you know, or you should know. So that was really intense. You know, there was time taken when we had shorter shifts, 8-hour shifts. You'd have an overlap. Earlies would come on, say 7:30 in the morning, go home at 4:35 or 5. The lates will come on, say 1 o'clock, and then finish at 8. So you had an overlap of a couple of hours. That time was spent lecturing, teaching, updating. Now that's gone. It's all 12 hours, 13 hours. You're very lucky if you get out on time from an NHS shift, regardless of what level you're working at. I've not known anyone to get out on time. Never, unless they're crafty and they just say, right, I'm packing up my bags, and then bing, the clock hits 8 o'clock at night or day. They pick up their bags and they run. There are some like that, and good on them. But not everyone can do that. Emergencies arise, patients collapse, there's another cardiac arrest, something happens, and we stay. We stay because we want to keep the unit safe, the A&E safe, whatever it is. You know, we're not heartless. If we were, we'd be in a better position as a profession, for sure, if we were more business minded, because I think that's our downfall as nurses. We are not business minded enough, and that has definitely been taken advantage of. But I'm not even going to go there because it'll end up being a 20-hour rant. I do have some suggestions though going forward, but I've got that many. It's like a list, like huge, from people who've asked me, would I cover this? Would I cover that? Things I want to cover, and it's like, crikey. So I am doing my research and my due diligence, so bear with me, because what I want to try and impart is what it's like when you're hands-on, you know, what it's like at the coal face kind of thing. Right, back to yes, there is fresh evidence that there was a cover-up between the hospital managers and the doctors, that the structure of the unit, the plumbing, all the essential things that you need to run a unit. You know, you need to be able to wash your hands. You need to have sinks that are clean. And it's one of the reasons flowers were banned. If anybody's old enough to remember, flowers and vases were always put next to a patient's bed, mainly for older people. Not so much children, because children knock things over, but mainly for older people. Now, the flower water has to be changed every day, and in many hospitals it was, especially where I worked in Ormskirk, it was, you know, done all the time. It was one of the sisters' duties in the sluice was to clean and sterilise the drugs with bleach, and then refill them, make sure there was no leaves in the water, whatever. Why is that significant? Because there's a bug that grows called Pseudomonas aeruginosa, and it lives in damp, wet places, including sinks, including the drain. So in a hospital, sinks that are not used that often are often run to stop Pseudomonas aeruginosa collonating, growing in the sink part, because that can become airborne in hot water when hot water steam gets in the air. And if you have that in a unit, they're going to breathe it in. The staff are going to breathe it in. But because the staff are healthy, it doesn't really affect them, if at all. Babies, children who are, you know, on CPAP, on supplementary oxygen, they're breathing that in. So Pseudomonas aeruginosa and all these other bugs that are only dangerous to people with compromised immunity, like cancer or critical illness, are breathing this in. Now, one of the reports was written by one of the plumbers. Now, I don't have names or anything. This is only gleaned from all the news that I've read. One of the plumbers from the estates department wrote a statement in support of Lucy to say that these babies got their infections from the sinks because the sewer ridge was coming back. There was a problem with the pipework. There was a problem with the infrastructure. You can't run a hospital without that infrastructure. That's why everybody who works in a hospital is important, from the estates department and the electricians to the porters to the people who deliver the oxygen. You know, we couldn't function as nurses and doctors without them. And yet they're the forgotten heroes, really. It takes everybody to do that. And then we've got all these managers. We could live without many of them. In fact, we could live without them. We'd only need a couple of them to do X, Y, Z. I won't go into it here. But I think if we went back to how hospitals were run pre Tony Blair and Alan Milburn, before hospitals were NHS trusts, our hospitals would not only be more financially fit, but the money would be spent on the correct people on the ground, where we could take back the cleaners and the porters back onto the ward off duty, where people had pride in their work and enjoyed their work and gave of themselves, not in a sacrificial sense, but a sense of pride, a sense of helping patients, a sense of owning their role. It was a lovely role. It was so different. In the first 20 years of my career to the second 20 years is like night and day. And sadly, the last 20 years were the night. Horrendous. But I'll come to that another time. I've come across a lot of obnoxious, vile managers in my time, whose only experience of healthcare has been working in Carphone Warehouse or a football club or Marks and Spencer's. Yep. So yeah, again, off my soapbox. Right. So yeah, so this evidence of the collusion and Lucy Letby being a scapegoat, this started to ring alarm bells with me, because exactly the same thing happened at Stafford. The Stafford inquiry, the Francis inquiry that brought about protection of whistleblowers within the NHS. Sir Francis got that right, but is it still being utilised? Are whistleblowers being protected? Actually, they're not. They're hounded. They're treated despicably. And from the lovely messages that I've had from people who are or have gone through hell on earth at the hands of NHS trusts for speaking up about patient care or lack thereof, about bad decisions being made, about cover-ups, even though there is a duty of candour in place. These members of staff are hounded and mentally assaulted, stopped from gaining advancement of their careers. Yeah, and it's all very underhand and very dark and very abusive. It's abuse. It's workplace abuse. And the people who've written to me, my heart goes out to you. It really does. And I want to add another channel. I'm just trying to negotiate my time so that we can offer some peer support to you anonymously, because there is a way out of this. And I will come to NHS mentality, which is on my list as well, because NHS mentality is very, very real, very real. It's an indoctrination, but we'll come to that again another time. God, I'll be here forever. Let me see, and I am going to increase the frequency of my videos as well, because I'm going to have to. I started this because of love, and I still love what I do, but it's like turned into a full-time issue now. So I want to get my point over more succinctly and do things a little bit differently. I've got a few things in mind. So yeah, so please stick around and like and subscribe and make a comment, because it all helps my channel to grow, because I want to reach all nurses, younger, older, people in healthcare, doctors, whatever. I need to reach to them so that they can have the strength to be able to deal with these issues. And again, I'll go into that, wink, wink. I'll go into that another time. Right, the above details. So the failings, yes, Stafford Hospital and many others. There are others. The maternity units, that's a whole nother ball game, because maternity units have neonatal critical care and special care services attached to them by the very nature of multiple births, triplets, twins, whatever being born, who may need to go incubated over to a bigger hospital for more specialised care, or to be in the nursery and observed more often, or increased medical care. comments to others and deadpan attitude. Lucy was criticised for having a deadpan face. Well, what does anybody expect, particularly the media? What do they expect of her? You know, is she going to do backflips and be laughing her head off? I mean, really, you think about it. If somebody had a camera on you and doing these videos, you know, those cameras really make you feel very much in the spotlight. You know, they highlight so much, and you can be very, very critical of yourself, how you stand and how you posture. Lucy, what else can she do? If you've got cameras in your face and a court artist sketching you, this is a very serious subject, very scary. I bet she was so anxious. She must have been terrified. I would be. What do you do if you're faced with the police and things like that? You know, it's, for most law-abiding citizens, it's very scary. You wouldn't know what to do. I've served as a juror about 5-6 years ago, and I thought, oh, crikey, no, please don't let me be doing jury service, particularly on a subject that's really emotionally scary. And yes, it was the P word. Some creeps had done the P word to children, and I was crying. I was literally, the tears were pouring down my face, and I got told off by one of the barristers because it was causing issues for the perpetrator. Oh, what a shame, eh? So we were left. We had to leave as a jury. They had to get a new jury in. Pardon me for being human. Because I couldn't bear to hear, and he was only reading out the charges, and there were about 30 of them, and it was horrendous, and in detail, and it was like, oh my God, I can't believe that creep is sitting like 20 feet away behind that glass, you know, grinning like a Cheshire cat, and this guy's reading out all these charges that, oh, it was horrendous. So how are you supposed to sit in a court? Grinning, big smiles? I mean, you are going to be deadpan. You're going to be shocked, I would imagine, and very anxious, and listening to every word and the implications of that word. And your barristers, you know, also doing the same, and interpreting all this for you, you know, legally, what the implications of that trial mean for you, for your freedom, for your life. I mean, this is serious stuff. So you're going to be deadpan. I'm not surprised if she was on anti-anxiety meds or antidepressive meds, because the stress of being arrested, I can't even imagine what that would feel like. And I think anybody law-abiding would say the same. If someone turned up at my door and put me in handcuffs, especially behind my back, that would kill me off anyway, because I can't move one of my arms around to my back. But oh, I don't know. I don't know. I don't know what I'd be. I don't know what I'd be thinking. It must be horrendous. I think if there were, you know, very clear-cut signs that somebody had committed a crime, that's a different story. You know that you've done something wrong, and you're paying the price for that. You know, society needs rules. It needs structure. However, if you haven't, and this is all on hearsay, well, you know, what are you going to do? Well, how are you going to sit in court? What expressions are you going to have? Yeah, so I don't know where they got this. She's got a deadpan face from. It's unbelievable. Okay, what else have I got on my list? Because I actually wrote out quite a few things. That was it, the consultants. Some of the criticisms about the doctors, and this brings me to why that baby unit was upgraded, i.e. why it took patients, babies, that had higher levels of care needed, higher levels of medical care needed, and yet the structure and the culture of the unit didn't change, i.e. the consultants were alleged to have only carried out 2 ward rounds a week. That should be a minimum of 2 a day. And more usually if a patient's going in the wrong direction. Normally there's a lot more medical input from a senior. No understanding of resuscitation. What? They never heard of PALS. Pediatric Advanced Life Support, that means not PALS, the people you complain to in the hospital. That's a different thing. That's for another video too. But paediatric advanced life support is a must for nurses and doctors and advanced practitioners, advanced nurses working in any unit, any critical care unit. I was one of the first to do the advanced cardiac life support, as it was called then. It was children, adults, trauma and everything, because it was brand new to the UK back in the day. Early 90s this was. Today, those courses have been made more detailed and they're separate now. So you'll have paediatric advanced life support, trauma life support, children's life support, and you'll have adults. So yeah, they're all more detailed. But the paediatric, the babies in the unit, they will also have their own kind of protocols. For example, under advanced life support for adults, in cardiology like cath lab, you will have your own ways of doing certain things for good reason. So a patient who goes into a shockable rhythm and needs those shocks, they can have what are called stacked shocks. So you don't shock, do resuscitation and monitor. They're stacked, as in a shock is delivered, you monitor the rhythm, has it been corrected? No, you give another shock, and so on and so forth. So all these little unit specific life-saving protocols are there for a reason. They're life-saving in the context of that specialty. Mechanical ventilation. Apparently they were not, allegedly, up on critical care of the newborn. So had only an overview of mechanical ventilation, not in depth. So I would imagine there were anaesthetists around who were neonatology trained, paediatric trained. Were they not involved in mechanical ventilation? If not, they should be. And the same with the physiotherapists. Physiotherapists who perform chest physio, they usually use an electric toothbrush on babies to vibrate the chest if they're stable enough. They would know the specialist tasks and procedures to take place, and the settings on the ventilator and the overall care of those babies. So why didn't the doctors know? It just seems a bit odd that other multidisciplinary team members didn't give a point of view into this. Okay, ET tubes. An endotracheal tube, as I mentioned at the beginning of my video, is a tube that goes into the mouth and into the trachea. This bit, the rigid corrugated kind of ladder type structure called the trachea, that then goes down into the two bronchi, into your two lungs. Okay, and that tube sits just above where the bronchi divide, because it's one tube that goes into two, and that endotracheal tube has a number on it for its internal diameter. Not its external, its internal diameter, and it's measured in a unit called French gauge, so it can be a 1.0, a 2.0, and half sizes, so 2.5, 3.5, whatever. And in neonates, tubes aren't cuffed. So an adult ET tube or a bigger child will have a cuffed ET tube. That means there's a little lead that comes off with a valve on the end, and you inject with a syringe some air that does not go into the tube. It goes into the balloon that surrounds the end of the tube. So it helps to keep that tube in place. Ties and dressings keep that tube in place, but the actual tube itself has this cuffed balloon, and it just sits in lightly in the trachea. It shouldn't be overinflated, shouldn't be underinflated. If it's underinflated, air and oxygen escapes as it's being pushed in by a ventilator, and you get an alarm going off to warn you, minute volume low. So often it's the ET tube cuff that can deflate because of the heat of the body and many, many other things. In neonates, they're not cuffed because of damage to the delicate tissues, especially in prem babies. So they're held in place with tape to the mouth as like a special cushion dressing. That means if the baby's moving and whatever, tubes can move, can be dislodged or pulled out, even by adults. You know, one of the first things they do is go to whatever's there when they're lightly sedated, or you're doing sedation assessment. And one of the worries, which is why you have one-to-one nurses with the patient, is they'll pull that tube out when you're doing sedation assessment. So these babies had uncuffed but dressing held tubes in place. In one of the babies, or was it two? It might have been two. The ET tube, or the endotracheal tube for breathing, was too small. Now, to choose a tube that is too small for the baby, and these tubes are tiny diameters, I have to say, especially in preterm babies, I mean, minuscule. You should be an expert. Nobody who's got some experience without the qualifications, the management, the constant management. I don't mean, oh, you've done a course a year ago and 2 years later your unit's been upgraded, oh, I can intubate a baby. It's a skill, like anything in nursing and medicine, that you have to keep doing to stay on top of your game. So, for example, as an intensive care nurse, we did intubation practice in theatre with a consultant anaesthetist. That did not make me a specialist to put tubes in. What that did was give me insight into a scenario. If a doctor wasn't around for any reason and we were desperate, I would have a go if it meant to save a life. But it would have to be extreme. And I mean extreme, because there was always doctors around. So yeah, it wouldn't have happened. But it was an insight kind of thing. But I would not call myself an expert. If I was in the middle of a jungle and, you know, a plane crashed and it was needed to be done to save somebody's life, of course I'd have a go. Expert? No. Why weren't these doctors experts? If they were upgrading their unit by taking those babies and accepting those babies into that unit, by default, they're upgrading their unit from special care to critical care. It's the patients that are in there that determine the unit, not the name. You could have anything above the door, you know, major critical care for the whole country. But if you've got 3 old ladies sat there with a bandaged arm and a drip, it doesn't make it a critical care unit. It's the patients you've taken, and it was up to the consultants to accept those patients, not anybody else. It was the consultant's decision. So, how on earth do you intubate a baby with a tube that's too small when you're supposed to be an expert? So someone somewhere has decided that they were going to take these tiny babies and intubate them and ventilate them. But as I understand it, the unit wasn't for that purpose, and certainly looking at the infrastructure, wasn't fit for that purpose. Weird. Traumatic and poorly supervised intubation. So if someone was supervising one or both of the babies, who was supervising? And if they were supervising and the person performing the intubation, the breathing tube, was unable to insert it once, maybe you try again, you oxygenate, and then let's go again when the baby's oxygenated and as safe as can be. These children are not stable. Let's just get this right. Anybody in a critical care unit is not stable. When qualified, experienced doctors and nurses in intensive care say stable, what they mean is they're not dropping their blood pressure dramatically. They're not stopping breathing. They're not needing more and more oxygen and you're constantly having to do something. What they mean by stable is that those ups and downs have stopped for the moment, because intensive care is a time and trend situation. You're looking at a trend over time, hour by hour, minute by minute, month by month, week by week. I mean, it is. And as I've said before, that trajectory can be on the up, that the patient's getting better. They stay stable, but the trajectory is either slightly going up towards recovery or it's slightly going down, which means demise. They're needing more oxygen. They're needing more drugs to keep their blood pressure up. They're not responding to antibiotics. They're continuing to get sepsis, etc., 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 etc. So once these babies were, and the word is used in the court documents, stable. They're not stable. They've been adequately oxygenated. The doctor putting the tube in would then have another go. If they can't get that in second time, whoever's supervising, whoever's more senior, whoever is in charge of that procedure, they should take over immediately. You know, ventilate that patient, get them oxygenated again, because 2 attempts have tried. Let an expert do it. Ideally, no one who hasn't got the capability should be intubating them the first time anyway. That should be an expert. And in the units I've worked in, it's always been our consultants. And I was very fortunate to work with the best. I've worked with fantastic doctors throughout my career. I can't say otherwise in my intensive care career anyway. Yeah, it's unbelievable. The other things that were noted about the children were things like the nasogastric tube and injection of air. Again, this is, what can I say? Unheard of. Unheard of. Air getting into the stomach can only happen to such a severity that the diaphragm, the muscle that separates the chest from the abdomen, becomes splinted, not splintered, as some people have, journalists have documented. It's got nothing to do with splintered as in splinters like in wood, where bits come off. No, splintered as in supported, like a splint, like an arm splint if you've broken your arm. You put a splint on it to keep it still. The diaphragm is a muscle, a dome-shaped muscle, that keeps the chest in a vacuum. There's no air in there. It's a tension. Again, that's why cardiothoracics is a whole other game. And if air gets into the chest, the lungs or lung can collapse because there shouldn't be air in there. Air and oxygen at a molecular level is a different thing to air being in the chest cavity. Okay, so again, without that knowledge of anatomy and physiology and pathophysiology and critical care, it's a very difficult concept to get your head round. So splintered, as in the stomach being filled with air, CPAP masks, for example, can't be put on too tight on babies and young children for various reasons, one of them being their face structure, the tissues are more delicate, etc., etc. So in one of the reports, it was noted that the CPAP mask used to be filled with cotton wool or gauze to prevent too much of the pressure escaping, not the air, the pressure, the CPAP, the positive pressure within the circuit to help the patient breathe, was filled with cotton wool. Doesn't suffocate, doesn't cause issues. Often in operations there can be swabs put in the throat, a different colour with a tail on, so anaesthetists know they're there for many, many reasons during ventilation. And that's why you've got experts, because they know what they're doing. If you're trying to explain a complex medical procedure performed by experts who have trained long and hard and have lots of experience to somebody who hasn't got a clue, like a lawyer or a judge or whatever, that's really hard to get your head round. Not because they're stupid, far from it. They just don't, they know law, they're experts in law and court and legal processes in a way that I and many of us could never be. But the way that some of this evidence has been presented is very difficult and I feel has maybe not been explained well. So in summary, I'm coming back to my first point. All courts, I believe, should be modified when they're dealing with highly complex medical issues, maybe other issues as well, I don't know, engineering or I don't know, whatever. But in terms of nursing and medicine and patient care, I really believe we should have 2 juries. I really do, and I'd offer to be on that jury, because unless you have, your fellow men, trial by jury, and a medical jury, nursing jury of experts who are experienced in critical care, I think it would be very, very difficult to reach a conclusion about what's happened and really understand what's going on. Now, if that was the case and courts were changed, because they seem to be sort of set in, I don't know, days of yore, there seems to be very little flexibility in the court and legal system. Everything takes forever, whether that's purposeful or not. I don't know. I watch Black Belt Barrister, and I think he thinks there are modifications that could be added to court procedure and law, but he's the expert in that, not me. But I really feel that if we'd have had this medical jury and have people on there, for example, I've worked with children in intensive care, special care baby unit when I did my care of the newborn midwifery module as a student nurse. I understand adult ventilation, I understand the culture in intensive care units, etc., 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 and I specialised in that field. So I understand the terms, and I could ask the pertinent questions. You know, why have you done that with a neonate, whereas with a child or an adult you would do this or this or this? So the right questions are being asked by people who understand critical care generally. I think nurses and doctors and staff who've worked in neonatal care, maybe retired or in another job now, they should come in and also ask the pertinent questions. And then if there is any discrepancies, maybe get the two juries together, the expert jury and the general jury, general public, with a judge, with barristers, whatever, and or a barrister who is not linked to either side of the case, to just sort of be an arbiter and advise a listener to make sure court process is followed, to say, well, this, and this needed to be looked at because my fear is this hasn't been done, or why wasn't that looked at, or, you know. So I think if that could be done, I think that's a good step to not just using the one size fits all that came from Beverly Allett. Beverly Allett's case was probably the first where the police were at a loss of how to deal with this and how to investigate it. So they had to do the best they could with what they had and what they knew. But the problem is that template has now been used for everything that's to do with hospitals and medicine. And a lot has changed in the NHS since Allett. I mean, Allett should never have been on a baby ward for a start. She was an enrolled nurse. She was not a registered nurse. She didn't have the knowledge, she didn't have the skills, and she was a master manipulator. And the nurse in charge of that unit, that ward, should never have allowed that gap to be filled by an enrolled nurse. But this comes back to money, doesn't it? Because the business managers who started to take over hospitals in the 90s were then starting to say, well, you know, we can have anybody put in place. We can replace an advanced neonatal nurse practitioner with a nursery nurse. You can't. It isn't about feet on the ground. It's about knowledge. It's about experience. It's about applying that knowledge, because that is the key to being a profession. We're not technicians. Registered nurses, especially specialist registered nurses in critical care or in critical care environments, are not replaceable like for like. They're just not. And in terms of pay and conditions, that's another bugbear of mine, is that you're working in critical care, but your pay is the same as if you were working in an outpatient clinic, 8 till 4. It's a disgrace. So if anybody's watching this as members of the public and you see on the mainstream media, oh, there was a nurse paid £1,000 for her shift in London on a unit, just take a look. The highly paid agency nurses are paediatric nurses, and they're often working in paediatric intensive care units. They deserve that pay. They deserve it. And if the health service want to be business-minded, money-minded, then let's flip it the other way, shall we? Let's reward doctors and nurses for the skills, knowledge and experience that they have. If it's a business, you pay for that skill, you pay for that experience. Otherwise you don't. Otherwise you get, you know, a normal banding or pay rate. Specialist skills demand extra training. Extra training demands experience. Experience is what you're paying for. Yeah? It's the same happening in plumbing and electricians. You're not paying for a plumber. You're paying for their experience. You're paying for that knowledge and their skill. So why doesn't that apply to us? And while I'm on my soapbox, sorry about this, if you're still here, thank you. The private sector don't pay any more to a nurse, a registered nurse working in intensive care, or like the Portland Hospital, neonatal intensive care midwives and nurses, than they do in the NHS. They use NHS rates. How convenient, when they're a business getting paid lots and lots of money. Why aren't they paying their nurses and midwives privately? I wonder why that is. That's for another day. Again, another topic on my long list. Anyway, I've got to end it here because otherwise we sat here all night and I don't want to bore you rigid. Thank you. Thank you so much for all your comments. Keep them coming. Like and subscribe, you know, the usual. You hear it on everyone's videos because it does make a difference to the reach of the channel. And I'd like to reach anybody who's interested in NHS care, anything newsworthy about the NHS, and anything that I can try and give another frontline side to when you're reading about the NHS in the press. So I might come to the private sector on another video, but again, it'll have to be at the back of the queue because I've got ALET to do and lots of other things, and I want it to be right. So if you want to hear any more, like and subscribe, get these videos out to everybody, and let's not leave the NHS in the hands of wolves to be decimated and taken apart, because the more educated you are in the public, whether you use the NHS, whether you have done, whether you don't, whatever, you've worked in it, the NHS is going to be taken from us. It's going to be modified and changed to such an extent it won't be recognisable. And those basic tenets of free at the point of delivery are really important. We only became a society with the money to have houses and inheritance to our children, and free money to go on holidays and do things, because we had a welfare system that provided council houses. You remember those? They're like rare as hen's teeth now. A system that enabled you not to starve when you lost your job, and a system that provided free healthcare. That fear has gone of paying a doctor or a nurse. So let's keep it going. And the only way we can do that is by educating the public and allowing you to cast your votes and speak widely and protest against any changes within the NHS. Okay, thank you so much. Again, keep them coming, and I'll be back doing another video. Take care.